Thank you so much. Thanks, Meeta. It makes me so personal with you. Thank you so much. So you want me to?
Yes, ma'am. Please, ma'am, you start with your keynote address. We are all eagerly waiting for you.
Okay, I'm so sorry. That's the last one. Okay. Many thanks. And I think that we are running short of time, so I may skip also some slides. But I thought that Anju, we knew that Jaipur had only one color and that was pink. But you did take us to Vibgyor. Fantastic. And Binal, you will not escape that you have been the culprit for this talk. You find here Dr. Metalia's also picture here, because if you recall, Binal, you had told me when I was to give a talk on exocrines that, oh, I know. I said, oh, you know the word? I thought that it was coined very recently. And how do you know? So then she talked to me about hers and family's interest. And that I thought at that time that Dr. Smith is not only an orthopedic surgeon, but he is also somebody who's an expert in sport medicine. So anyway, we would have his words also. So this is on behalf of, and Urvashi's picture is here, because when Urvashi and I and Rashmi and others, when we thought of Indian Menopause Society, I had thought of much more for research, and she was very keen on the services. I think both are equally important, because unless you translate your research into meaningful services and guidelines, it is useless to do such a research in isolation. So with this Vista vision that we are talking about, Kasturba Society Medical Research Center, all my colleagues who are a part of this webinar are very thankful to all of you for making us party to this Vista vision of IMS. Thank you. So, genesis of today's talk comes from, as Meeta rightly said, that Dr. Vaidya is very much interested in urine therapy in Ayurveda, ancient insights to modern discoveries for cancer regression. And this is in PubMed Index Journal, JAIM, and I would say that those who are interested can go through that. What was very interesting to our group, Thursday meeting group, where all these scholars you can see, one of them is with me here helping me out, and Prajakta Paradkar, whose work on PhD has been quite a bit on phytomolecules and the in vitro. And also Siddesh is working on cow's urine. So much has been talked about it. So let's find out objectively how good is cow's urine for anti-cancer activity. He's doing it in vitro work. And loading-induced anti-tumor capability of murine and human urine has been an excellent article that Dr. Vaidya told us to read, and after that, I think that it is he has put us on a little faster track for this area. Next slide, please. And other person who also, I would say, Astha is very much with us, that when I was preparing about the exocrine talk, I had in my mind what they are working also on, and the red plantar fascia stem progenitor cells showed lower expression of ligament markers and higher pro-inflammatory cytokines after intensive mechanical loading in vitro. Definitely put me my mind towards to this topic. I said, wow, let's see what is happening to women. And decreased methyl trioxide mediated protein glycation in the healthy aging mouse model of ectopic expression of UCP1 in skeletal muscle. And we are very keen to listen to her today. Next slide, please. And while I'm on my gratitude towards everybody who makes your journey possible, unless, and that is a group genius. Our Indian Menopause Society is also a group genius. The same way, Ashwinikumar Society's Medical Research Center, there is a group genius. And you can see here, our research director, Dr. Shobha Pudigi Madam is here. Also, you see our president, Dhirubhai Mehta, and others, and Dr. Jayashree Joshi, who is a member of Indian Menopause Society. I'm so glad that Dr. Raut agreed to participate today. Thank you so much. Next slide, please. So when it comes to the flow of the Vista vision, I think I will touch upon plantar fasciitis, foot pain or heel pain in general, and at menopause. Talk about the diagnostic modalities and management strategy. So both this will be dealt with the other speakers. Gender specificities, if any, and the role of estrogen. I find it really, I'm surprised that there is very little of literature of the plantar fasciitis at menopause. I'm surprised. It could be my review literature is defective. If anybody has more, you can always add to that. Gender specifically, Fanny, and the role of estrogens, resistance exercise for the subject, outcome, barriers, and molecular mechanisms, and exercise as exercise mimetic for the plantar fasciitis, and the lived experiences of people with persistent plantar fasciopathy. With this, the next slide shows that a large amount of work has been done by Thomas and colleagues from UK. And in their more than 5,000 responders, they found that the plantar heel pain was 9.6%, but they were very keen to see that there may be heel pain, but does it cause the disabling plantar heel pain? It was a little less, but that's a very important area. No gender difference was talked about in this, and again, that's why there is a missing aspects of menopause and the plantar fasciitis. General and psychological health was affected. They say definitely it interferes with daily life and social isolation, anxiety and depression. If there is a the walking group, then you get out of that walking group because you have so much of pain. They also identify risk factors for plantar fasciitis, that is obesity, sedentary lifestyle, excessive running, prolonged weight bearing, flat feet, or high arch feet, overtraining, reduced estrogen level, recent stress fracture, poor footwear, or walking bare feet. And I was expecting it and I didn't find that many a times if you see the villagers and village women and others, they wear chappals, which are often, I think itself can cause some trauma to the fascia. So I think there is a lot to be excavated or learned in connection with Indian reality. The next slide, please. So the assessment tools for foot pain, disability, and function, there are many. And the one which shows here the pictures is the foot posture index. The safe range you can see in green, where proper pronation, normal or little deviation, or supination and a little deviation. And I'm sure that Dr. Monasha would be talking a lot more about this. So I'm just touching upon with a picture, we can feel that if it is unsafe range, how that foot looks like as an over pronation or over supination. And plantar fasciitis, 13 to 36% in women, this prevalence of foot pain across an international consortium of population-based cohorts is what looking at. And I think the next slide may show that. Yeah, it is there. This international study, there were five, the articles were from the five different authors, and it varied from 13% to 36%. And in Framingham foot study, it was 25%. So this kind of a 13 to 36% is quite a range, and this may be affected by the case definition that was used. And so this investigators say that if you really want to do an international consortium of population-based cohorts, first you must plan it and you must agree to the definition for the the subject that you are going to define. What are the indices that you are going to define must be agreed upon right in the beginning. And in India, I find, and Dr. Smith will be, Dr. Matalia will be able to tell us a little later about that. Are there many studies? And I did not find many. If those which are coming, they're coming really from ultrasonologists. And that's why we will have some ultrasonologists picture of the subject. Participants had a high BMI and a higher percentage of females. They say so, but they do not make any mention that if it was in females and if it was at old age in females, whether menopause as such had anything to add to that. Plantar fascial thickness and heel pad thickness were high in affected foot. They had done this study in those who had unilateral uh, plantar fasciitis. There was no significant association between various clinical, metabolic, radiological risk factors, and the intensity of plantar fasciitis was measured by foot function index. Again, a good study to read because there are very few from India. Next slide, please. So plantar fasciitis relates to repetitive stresses and reduced ankle dorsiflexion, dorsiflexion. Chronic inflammatory disease is a question that has been asked. Asta, it is a question that has been asked, but there are some who says it's a chronic degenerative disease. This can be discussed sometime. Linked to other disease groups like diabetes, rheumatological diseases, and I'm sure that this differential diagnosis, and Dr. Raut is going to deal with this subject. Can we have genetic factors? Dr. Rama Vaidya's PhD scholar, Asta will be talking much about this. The Vinlas have high specificity, 100%, but low sensitivity for EF. X-ray for plantar fasciitis and the calcaneal spur, and ultrasonography, hypoechoic and increased thickness of the fascia. So actually, if you really speaking, go through this updated review, which is of 2023, takes about the entire subject. Anybody who wants to study this as an entire subject, get introduced to, this would be the article beside Thomas's article that I talked about. These are two articles which are really introduces you to this subject. And so at any point of time, Meeta, if you thought that it would be worthwhile looking into this and introduce ourselves to some extent to go through this, and through different lenses, we can make a group and start looking at this in Indian context. Next slide, please. Assessment tools for foot pain, disability, and function. The proper dorsal flexion movement of the first metatarsophalangeal joint is crucial for an accurate gait. And biomechanical effect on Jack's test on barefoot position, regular stops, and biomechanics is a good article, which maybe the next slide might be showing that. Is it that? 1 second. No, it's something different. So plantar fasciitis is a degenerative condition, and they are trying to say that it is not so much of an inflammatory, but it is much more of a degenerative. And female males ratio is 55 to 45, and influenced by rheumatic condition that Dr. Raut will be talking about, genetic factors that Ms. Asta will talk about. 1 million people in US to visit a physician per year for this condition. 1 million people in the US to visit a physician. And the prevalence of the condition is estimated between 3.6% and 7% among runners. And so I think that with our interest now in our country, those who have disability and those who are special, there are specific games and special game arrangements for them. And so there is an importance of not only the sports medicine expert, but it is possible that orthopedic surgeon and others who take interest in specifically plantar fasciitis maybe get together to see that their running is made smoother. Annual consultation prevalence was 290 per 10,000 registered persons UK. Next slide, please. So what is the cost? What is the economic burden? The economic burden, the Here you can see that the Korean National Health Insurance, according to that statistical yearbook, the number of patients treated for plantar fascial fibromatosis and fasciitis, and with the I see the number from WHO, which is M72.2, increased from $89,900 uh, in 2010, 2018, it had increased so much, while the treatment cost has increased from 5.6 billion to 19.1 billion in Korean currency. I do not even have whether we are organized to deal with this condition, when I think that for the people who are interested in sports medicine, women, the organization like ours, we are interested. And I think it would be high time that we start looking at this. And that's why sometimes when I watch, where I had watched Jaideep, and I'm thankful to Jaideep's presence here, Dr. Malhotra, that, it is so much for wellness when we are talking about that all groups of women who are trying to come out of their disability, or they're specially challenged. And for that, I think again, our indulgence in topic will be worthwhile. So the healthcare usage and cost for plantar fasciitis are retrospective observational analysis. There are 2 articles. It might be a good idea to go through this and try and do whether we have any organized efforts in this area. Next slide, please. So what are the symptoms and signs of plantar fasciitis? Plantar fascia originates from medial tubercle of the calcaneum bone, proximal to the attachment of the muscle, that is flexor digitorum brevis, and then divides into 5 processes near the heads of the metatarsal bones, where it inserts. It provides support to the longitudinal arch of the foot and is a dynamic shock absorber during foot strikes. Pain on sole of foot, pain while taking the first step of the day in the morning when one wakes up from bed is a classical symptom by history you can take. Pain on prolonged weight bearing, increase with physical activity. Again, I'm trying to quote the same article, and this updated review takes care of all aspects that you can deal with in this area, except that they have also not made any special mention about the subject related to menopause. So plantar fasciitis remains absent for menopausal health, even in the world literature, except there are few isolated articles. Next, please. Now, comparison of radiological features in the affected and unaffected leg has been studied by Tiwari's group, and ultrasonographic assessment of Indian patients with plantar fasciitis and its clinical correlation. A prospective observational study was done, and this is being reported. 34 articles from 31 studies involving so many participants provided. Now, pardon me, I don't think I've read it completely and properly, so as to say that where are these participants coming from and what are these 31 studies. And that's why I just didn't have time. But if I have to put in time, I'll go back to this one article, because this is the Indian article, and large number of articles world over are coming from ultrasonologists. So I think it would be a worthwhile to look, because once you have made it suspected, tentative diagnosis of the condition, then you want to confirm it both for therapeutic monitoring through the intervention, as well as confirming the diagnosis, then you go to ultrasonologist. Next slide, please. Now, although a higher rate of plantar fasciitis in women than men has been reported in the military, little has been done to examine the effect of estrogen on the plantar fascia. There is no change in elasticity of the fascia in men at 2 time periods. Here you can see the picture. In this, what you find is that blue color is for menstruation, the saffron is for ovulation, and then males and females are another 2 colors, the gray and the bright yellow is women. So there is no change in elasticity of the fascia in men at 2 time periods. However, there was a distinct change in elasticity of the fascia in women during menstruation and ovulation. At ovulation, there is an increase in elasticity of plantar fascia. And that's why those who are trainers for the those who participate in any kind of sports or also marathon or whatever it is should keep these things in mind. And that's why this article again, differences between men and women in balance and tremor in relation to plantar fasciitis during the menstrual cycle becomes an important one. And it is possible that my colleague, Dr. Monasha, may be touching upon this area also. Next slide, please. So there are different kind of maneuvers. One is Jack's maneuver, another is pusher. The arch of the foot rises with dorsiflexion of the hallux. The posterior part of the foot assumes an inverted position. The leg rotates laterally. A tight band is noted in the region of the plantar aponeurosis. That means this word is that whenever the plantar fascia is like a tendon only, it's very thick. In addition to elevation of the MLA, medial longitudinal arch. So next slide shows that to measure the resistance to passive dorsiflexion in the first metatarsophalangeal joint under 3 different conditions: barefoot, wearing regular socks, and wearing biomechanical socks. Using digital force gauge is also seen here. Utilization of biomechanical socks with a kinetic wedge, reinforced mesh in the medial longitudinal arch and padding in the heel area results in reduction of the force required, measured in newtons, and to perform dorsiflexion of the first metatarsophalangeal joint during Jack's test compared to being barefoot or wearing regular socks. So in the Jack's test, this is a special feature that there are 3 measures by which they three conditions by which they measure the force. Next. So this is ultrasonographic assessment of Indian patients with plantar fasciitis. Its clinical correlation, a prospective observational study. Ultrasonography is considered as a very sensitive, specific tool to identify patients with plantar fasciitis. In this picture, you find that USG picture showing normal level of pad thickness. And you can see that between the 2 yellow arrows. The second picture shows thickened and hyperechoic plantar fascia. So beautiful picture this is. And I don't think that whether you do USG, and some of you might be experts and you may want to start because I think that our own society is so versatile that some people who have within their infrastructure ultrasonography possible. So with the appropriate tools, maybe this could be included and you can see it for yourself and take also the history as well as confirm the diagnosis through ultrasonography, which is a very sensitive, specific tool to identify patients with plantar fasciitis. Next slide, please. Is the next one. So ultrasound strain elastography reliability and assessment of the plantar fascia and its relationship with plantar thickness and health in healthy adults, and inter-observer reliability study in novice evaluators. Because I thought that some of you may want to take up this topic, or your MSc student or DNB student, and that's why it also shows that there is a, what is, if you may say that this is looking like a definite diagnosis, the other one may not agree. So this has been done in intra and inter-observer reliability study in novice evaluators. It might be worthwhile going through this article. Well, ultrasound strain elastography biomedicine journal 2023 would be worthwhile. Next slide, please. Okay. And they also give long axis images of medial portion of plantar aponeurosis in 44-year-old symptomatic patient, where they've given the complete history and then this ultrasonographic picture. So once again, though I've not put the reference here, I don't remember exactly whether it is from that earlier one or this was a separate, but if you once write about one case report, then it is in a 44-year-old symptomatic patient. And later on, when the Asa will talk about Professor Vidita Vaidya. She was 43, 44 when she had experienced the plantar fasciitis. Next slide, please. Exercise and menopause age-associated sarcopenia. We all know that there is much more sarcopenic obesity at a transition and later on if it's not taken care of. Simultaneously, that's why they say to maintain a good arch throughout life, you may not be having flat foot earlier, you may not be having the long arch also, but your normal arch can be maintained only if you commit to appropriate exercises. Exerkine apelin reverses age-associated sarcopenia. I talked about it, and I wanted so much Binal to be present at that time. She had some commitment, she had gone. She said that I chased her. Yes, I chased her because I thought that why she was not present for the first talk when she said so much and also about her brother. So with that, I approached her, I called her, and there she was. And I think we have had last 1 month, must be if she looks through her mobile, then it is stored all the things that we have been talking about to each other. And that's why I thought if the exerkine is available, sometimes those who are so disabled, will we be able to use this exerkine, which is apelin? I don't know, but whether it will be available for applying to this condition. And so that those who are marathon workers, and if there is anything, can be offered to them. Next slide, please. Sensitivity of the fascia to sex hormone levels, modulation of collagen 1, collagen 3, and fibrin production. Dr. Vaidya was very keen that I talk in detail about this. But I'm so sorry, Dr. Vaidya, if you are present with us today, right now, then I have not gone into that much of a detail for me to talk about this. But only thing that those of you who are basic scientists and want to look at this area, then this is a good article. I superficially looked at it. Next slide, please. Okay, this is the topic which is being going to be dealt with by Dr. Raut, and I will look forward for him to talk us about which Achilles tendonitis, with plantar fasciitis, what are the differences, and plantar fibromatosis. I was shocked to read about this reference which is given here of the fibromatosis, how painful this condition is. I did not read completely to see that is it only the area where Dr. Natalia comes into picture, or there can be anything that the physiotherapist and others can do about it or not. But it is one of the conditions that happens if you neglect the plantar fasciitis, then you may result with the fibromatosis. Next slide, please. So this again will be a topic that Dr. Raut will be. So I have just put it here. That's all. And this again, one thing that Dr. Vaidya has been, as Meeta right away said, extremely interested in any modality that exists in a large number. We must look at it, what is its effect. So how effective is acupuncture for reducing pain due to plantar fasciitis? His Singapore colleague writes that although acupuncture may reduce plantar fasciitis pain in the short term, there is insufficient evidence for a definitive conclusion regarding its effectiveness throughout in a longer term. Again, it would be interesting, those who are interested in this area, and I find that some of the doctors themselves become experts in acupuncture and acupressure. Next slide, please. However, uh, okay, muscle strengthening exercises are putative psycho-socio-cultural barriers. Whenever you give a title, and I gave hi-fi title by saying that there is a barriers to strengthening exercises and at a molecular level. So I'm very, very glad that at a molecular level I have a colleague to talk about. But all of us can, putative psycho-socio-cultural barriers, we can imagine. And what imagination comes to my mind has been that there may not be a necessary gender discrimination. Physiologically, women may be different. And through the pregnancy and other phases that we go through, that could be something different. And so, enablers and barriers to older people's participation in strength and balance activities, a review of rewards, review of reviews, I would recommend this article for sure. Those who are interested could look at this. And effectiveness of intrinsic and extrinsic muscle strengthening on heel pain in postmenopausal women. This is the only article from India that I have seen, and in the world literature, I did not find much literature related to plantar fasciitis in menopause. Next slide, please. This is my last slide. Mukam karoti vachalam pangulam langayate girim yat tamaham vande paramananda madhav. Certainly we would pray when we have that pain. But plantar fasciitis, if untreated, what would happen? Small tears, micro injuries, plantar rupture, and fibromatosis that I talked about, spur formation. So the consequences of leaving plantar fasciitis untreated are many. There's a good article, please read it. A study of calcaneal spurs in Indian population is one more article, might be worth reading and looking into. So this was the last slide, and thank you so much.
Before the chairperson says anything, before the chairperson, sorry, this was one aspect of madam that we missed out. She's always way ahead of us in menopause medicine, any aspect. Thank you, madam, for always being our teacher. You have always taught us, never learnt anything, always taught us. Thank you so much, madam. Brilliant.
Absolutely brilliant, ma'am. Salute to you.
Who's this?
Jaydeep.
And a person who I feel has started 35 plus club, she has an opportunity because she is also a multitasking person. So maybe that those who are runners and others, because you people with Dr. Malhotra organize such activities for the health, and you may help some of them there. Thank you. Thank
Sure,
you so
ma'am.
much.
This is a great, insightful deliberation on a topic which is absolutely never discussed. Thank you so much. It was absolutely wonderful.
Thank you.
Can we now have comments from the chairpersons, Dr. Smith, and then Dr. Meeta will
I have
conclude.
been waiting
Dr. Smith.
for Dr. Smith's comments. Yes.
Really, yeah. Hello, everyone. It was a wonderful talk, madam, and it's one of the best lectures of plantar fasciitis that I have attended personally. A very in-depth and detailed coverage of all the factors. I especially would like to highlight the point that you said the risk factors covers on the either side. One side is the sedentary lifestyle, and on the other side is the excessive training also. So one must be aware that plantar fasciitis can also it can happen because of the sedentary lifestyle, overweight, and weakness of the muscles. And on the other side, the excessive training in the people can also give rise to plantar fasciitis, along with the deformities of the foot and lower limb can also give rise to plantar fasciitis. So broadly, you can, differentiate plantar fasciitis between repetitive stress injuries, or due to sedentary lifestyle and weakness of muscles, or it can be also due to inflammatory pathologies. So we need to diagnose which condition our client or the patient is having and accordingly treat it. Very nicely, madam, you have taken up all the parts of the plantar fasciitis, one of the best lectures that I've attended. Thank you so much.
Thank you. Thank you so much for your presence here. And we may talk.
my
I will
pleasure,
take your phone number and we may talk further. Thank you so much.
Sure, madam. Sure, madam. It was a pleasure. Thank you so much. Over to you, Hinal now. Yeah.
Yeah. Meeta ma'am, would you like to give any more concluding remarks? Thank you, Dr. Smith.
Unmute.
Ma'am, please unmute yourself.
I said brilliant, and as usual, a well-researched presentation, put it in a very concise form. And ma'am, I could relate very well because I suffered from plantar fasciitis. So I had done some kind of a research on it, and so it was. So I was very impressed with that Appelin slide that you put in. So it's not about risk factors, because risk factors very nicely said that nothing comes with the excess. It's always that curve is in between. But what fascinated me in your slide was that particular one slide where Appelin may reverse the sarcopenia or those So one of those exocrines that probably put you into this. So that is really wonderful. It's always food for thought at the end of ma'am's lecture.
Really.
2002, she had spoken about sarcopenia. The first time we heard that term sarcopenia.
In that meeting, yeah.
And all of you are very right, ma'am, because when we were discussing about topic, she herself said that when I am to speak, I have to speak something which people have not heard about.
Yes.
So, this is her exemplary thirst for knowledge.
Absolutely.
And she is an enthusiastic student, I must say, a very passionate student in pursuit of science. So really remarkable and incredible talk, ma'am. Thank you so much.
Madam, so much thank you, because I also suffered in 1998 with plantar fasciitis, and I started walking in 2001. That is when I researched and I started walking. I started taking 4.5 to 5 kilometers of walk. I think the sarcopenia was the main problem, and I found that, and I started walking at that late age. 2001, I started walking, and I never suffered after that. It's a beautifully explained, and I have myself been a sufferer in a great manner. I used to put those sponges and things in my shoes. I couldn't walk.
Yeah, that's why I'm really waiting for Mona's talk.
Yeah,
I'm
thank you.
waiting for Dr. Mona's talk and also Dr. Raut's talk.
Absolutely, absolutely. Thank you, ma'am.
Shobna.
Madam, this is an exemplary talk, and you proved that you are a great teacher, because the teacher is the one who provokes thoughts, not just teaching and learning. You provoked so many thoughts in us, and everybody started, oh, what research I can do with this. And we never heard that the plantar fasciitis can fit into IMS. So now nothing is left for the IMS to take any subject. Oh, really great, madam, to have this thought that the plantar fasciitis can come into the IMS. Thank you,
so
madam,
much
for provoking such a great idea to us.
Can I just say one word? From Patna, Dr. Kumkum Sen, I'm so impressed with madam's talk and her approach to life and how she keeps herself. Thank you so much, madam.
Thank you. Thank you.
Thank
so
you.
much. If
Thank
you are
you,
in Mumbai, please do come and visit us.
Yes. So thank you so much. And ma'am, right now you have presented just one lens, that is the clinician's lens. And in the Vista Vision, we want to present in front of the audience the perspective of different specialties. So with thanks to ma'am and thanks to the chairpersons, Dr. Meeta and Dr. Smith, I would hand over to the MOCs to take this session further, where we have different other specialties ready to present their lens of heel pain. Thank you so much, Rama, ma'am, Dr. Smith and Dr. Meeta.
So thank you, Beenal, for this even novel idea of the webinar. And of course, Rama ma'am is like spellbound and speechless after that. So to do more justice to the topic, I will now introduce our next chairperson, Dr. Anjana Pandey. Can I have her CV, please? So Dr. Anjana, yeah. So Dr. Anjana Pandey is a young rheumatologist practicing in Agra, and she has memberships of various national scientific and academic bodies, and she is a fellow of the Indian Academy of Medical Sciences with special interest in the field of osteoarthritis and crystal arthropathies. And she has guided and co-guided approximately 40 theses of MD medicine and other specialties, and with various publications in national and international papers in various chapters in API textbook of medicine and scientific updates in various journals. So I invite Dr. Anjana Pandey to this for the webinar to introduce the next speaker.
Thank you, Dr. Reshmi, for making me part of this August gathering. And I'm not that young. I'm also approaching perimenopausal stage. I'm 45 now. So this topic fits to me also. Thank you very much for making part of this CAV. I'm very thankful from core of my heart. Thank you very much.
So can we have the CV of the next speaker for Dr.
Now I invite I invite Dr. Ashwinikumar Raut. Can I have his CV, please? Yeah. Dr. Ashwinikumar Raut is a graduate from BHU and is currently Director, Clinical Research and Integrative Medicine at Kasturba Health Society Medical Research Center, Mumbai. He has guided many postgraduate theses. He is scientific advisor for many premium government institutes, and he has many national and international publications to his credits. He has received CDRI Award 2007 for Excellence in Research and International Dhanvantri Award in 2010 for Excellence in Ayurvedic Practice. Without ado, I invite for your talk, Dr. Ashwin Raut. Welcome.
Thank you, Dr. Anjana Pandey, for that introduction. I shall share my slides. Is it visible?
Yes.
Yes, sir.
Yeah, I will make it a slideshow. So, first of all, I must thank my mentor, Dr. Rama Vaidya, for bringing me here and giving me back to see through the lens of rheumatologist. This has been my subject of interest and subject of research. But for this small time of 10 minutes, which is assigned to me, I will try to speak the more ground realities of heel pain, its differential diagnosis, and highlight two most common conditions. And then we will address just bullet points of the current state of affairs in the management of heel pain. Coming to the heel pain preamble. Now, to say heel pain is a vague term which describes pain surrounding the calcaneus, most commonly felt posterior to the calcanea and inferior to the calcanea. Healthcare seekers for heel pain often approach, or most of the time they even do not approach. There is a self-medication being done. But if they approach to the healthcare providers, they first approach to the general practitioners, then to the orthopedic surgeons, then physiotherapist, and then rheumatologist or podologist. Unfortunately, podologist discipline is still underdeveloped in our country, and rheumatologists got recognition in last couple of decades. Heel pain, whether it is plantar or posterior, is a common disabling symptom among adults. This affects approximately 1 in 10, that is plantar heel pain is almost 10%, whereas posterior heel pain is 1 in 8. That means it is more than 13%. In adults aged 50 years and above in general population. So I'm talking about general population prevalence rate of 10 to 13%. Most heel pain arises from the pathology in soft tissue structures like tendons, fascia, and nerves. Apophysis and bony pain are less common, and most diagnoses stem from the mechanical etiology. The medical history and further clinical examination and investigations through imaging modalities remain important besides other case-relevant laboratory investigation as per the case it may demand. Age-related loss of muscle mass, we were talking about sarcopenia, in addition to low estrogen level related weight gain, makes peri and postmenopausal women vulnerable to musculoskeletal health issues. This is very important. And there are several studies which have suggested that the combination of sarcopenia and obesity, what we call it as a sarcopenic obesity, was more strongly associated with disability in postmenopausal women. Heel pain is highly prevalent in our society, but less aggressively attended by medical practitioners or medical and biomedical researchers. Coming to heel pain, let us see what are the causalities and what is the differential diagnosis. What I have tried to put down, as I said in earlier slide, that the etiology often is local, the mechanical. And there are also some systemic causes and referred pains which are causing heel pain. So let us see what are the local mechanical causes. And I have divided them into plantar, posterior calcaneum, mid-foot, medial, and lateral. And they all contribute to the heel pain. Now, plantar fasciitis, Dr. Rama Vaidya just talked about. But besides that, there is a heel pad syndrome. You know, there are fat pads underneath our heel, and that causes pain besides plantar fasciitis, which is most commonly seen. Calcaneal spur we know, but calcaneal stress fractures to this fat pad is important. And more than that, there is also a bursa underneath our heel, which also sometimes gets. So the differential diagnosis among the plantar fasciitis, calcaneal stress fractures, heel pad fat, and then bursa is very important. Posterior calcaneum. Now, Achilles tendinitis is the most common manifestation seen at posterior calcaneum. But Haglot's deformity, here you can say in the picture how this, you can see the broadening of the calcaneum at the posterior end. That and retrocalcaneal bursa, these three components always overlap each other, and the differential diagnosis sometimes becomes difficult. On midfoot, posterior tibialis tendinopathy. Here, if you can see in this right hand upper picture, that posterior tibialis tendinopathy, FDL tendinopathy, and follicis longus, that is these two tendons, what you can see, I hope you can make out from this medial aspect of the foot, these two tendons, they get entrapped, and if there is any inflammation due to systemic or local causes, that can cause heel pain. And also the tarsal tunnel syndrome, what you see here between the calcaneum and tibial prominence, that sometimes causes this tarsal tunnel syndrome, and which gives rise to pain at heel. Midfoot lateral peroneal, this thing is basically usually when there is a sprain in the knee. This peroneal tendinopathy, you can see here that sinus tarsi syndrome, because in this lateral side of this calcaneum, fibula, and tarsal bone, there is a gap, and that sometimes produces and makes it vulnerable for this syndrome or the sinus tarsi syndrome. Coming to the systemic or referred causes of heel pain, there are several rheumatological conditions which contribute to produce this symptom. And the commonest in rheumatoid arthritis is subtalar arthropathy, mid-tarsal arthropathies, and rheumatoid nodules sometimes appear at the back of this. Psoriatic arthritis and seronegative spondylitis, the most common manifesting feature, almost 35% of psoriatic arthropathies, they will manifest with Achilles tendinitis. Osteoarthritis, again, talonavicular, tarsometatarsal, and intertarsal joints, they will cause degenerative changes and produce osteoarthritis. There are almost 33 joints in our foot, and you can imagine 26 bones. How different manifestations can they cause? That fibromyositis, again, this is a very, in a way, debated subject, whether fibromyositis or fibromyalgia is considered as a physical kind of a illness, or it has a lot of psychological overlap. But fibromyositis and nodular fibromatosis, Dr. Rama Vaidya was also referring to, which is very painful condition. Gout, again, although we know that first metatarsophalangeal joint is the most common manifestation of gout of the thumb, but of the great toe, but the subtalar, intertarsal, and torsometatarsal also sometimes would be the presenting feature. So these differential diagnosis with relevant laboratory measures will help us to bring to the correct diagnosis. Dermatological manifestations like calluses, corn, fissures, foot fissures, warts, we all know, but psoriatic lesions and diabetic ulcers are also not so uncommon. Neurological, as I said about the entrapment neuropathies, particularly the entrapment of lumbosacral nerve, popliteal nerve from the knee, and posterior tibial nerve, what I was showing here, giving rise to tarsal tunnel syndrome, and then peripheral neuropathy, making the foot and the heel more vulnerable to the trauma. There are other rare causes. Now, Sever's disease is especially more seen in the children of younger age, developing children, because of the the different plates of the bone. They are in the process of development, and they may cause a temporary phase of severe pain in the calcaneum, and that may last from 2 weeks to 2 months. Infections of the bone, osteomyelitis, there can be tumor, osteoma, sarcoma, and vascular cause, but these are rare clinical conditions. Coming to the heel pain and Achilles tendinopathy, which we saw that it is one of the most common, and its prevalence is almost 13% in aged people beyond 50 in general population. So the Achilles tendon is formed from the merging of the soleus and gastrocnemius muscle, and it inserts into the calcaneum. The Achilles tendon insertion is a complex structure that includes the retrocalcaneal bursa and retroachilles bursa. So there are two bursae here, and that also makes it more complex situation to evaluate what exactly is causing the pain. Excessive mechanical loading of the muscle, such as the increased running, can cause tendinopathy that leads to posterior heel pain. Besides that, systemic disorders like seronegative spondyloarthropathies, we saw the psoriatic arthritis, then reactive arthritis, and so many other seronegative spondyloarthropathies often manifest enthesopathies having inflammation of Achilles tendon at insertion. The pain associated with Achilles tendonitis is achy, occasionally sharp, and worsens with increased activity or pressure on that area, or with passive dorsiflexion. The diagnosis can be classified as insertional or with the mid substance of the tendon, and that becomes again a differentiation. Now we all are using this fluoroquinolones. The most popularly used drug is ciprofloxacin or norfloxacin, and all these drugs are now have been shown to precipitate Achilles tendinopathy, particularly in older people. The first case was reported from New Zealand in 1983 with ciprofloxacin, so having this Achilles tendinopathy. But since then, the number is ever increasing. So we have to be very cautious when we are going to use this ciprofloxacin or fluoroquinolone group of drugs in elderly people. Of course, this is also a dose dependent, and the longer the duration it is used. Management obviously includes activity modification, eccentric exercises, reduction of pressure to the area, deep friction massage, tendon mobilization, and use of analgesics or anti-inflammatory medication, which has to be used very judiciously, and heel lifts or other orthotic devices. Coming to the another most common condition, Dr. Rama Vaidya has dealt with it, but what she has done is really taking us to the cutting edge
I
knowledge.
request you to conclude your talk in 2 minutes, please.
Yes, I will finish in two slides now. Only last two slides are remaining.
Thank you, sir. Thank you, sir.
But I must address to that what Rama Vaidya had taken us to the cutting edge knowledge exploration.
Sure, sir. Sure, sir.
Yeah. So coming to this plantar, I have just put down my notes in this slide. The primary symptom is usually throbbing medial plantar heel pain that is worse with the first step at rest. The pain often decreases after further ambulation, but can return with continued weight bearing. Palpation of the medial calcaneal tuberosity and along the plantar fascia typically causes sharp stabbing pain. Passive dorsiflexion of the foot and toes often elicit pain. Now, diagnostic imaging is not required, but weight-bearing radiography, MRI, and ultrasonography can help us rule out other causes of pain. Here you can see that fat pad pain will be more at the central, whereas the this plantar achilles pain will be more on the medial side. Heel spur are present in approximately 50% of patients with plantar fasciitis, but they do not correlate always with the symptom and can also be found in persons without the plantar fasciitis. This must be remembered. Treatment is typically conservative in plantar fasciitis with rest, activity modification, stretching and strengthening exercises, ice massage, and judicial use of anti-inflammatory and analgesic medicines. Corticosteroid injections increase the risk of plantar fascia rupture or fat pad atrophy, and that also happens to be cautiously used when we use this in the earlier description of Achilles tendinopathy. And I have seen patients getting rupture of this tendon post-injection, local injection. Now coming to the heel pain management, heel pain is a multifactorial problem, and hence the management has to be individualized. Clinical experience, expert consensus, and circumstances determine the comprehensive management of heel pain. However, many types of well-established treatments are available for heel pain, such as physiotherapy, splints, customized insoles, oral analgesia, steroid injection used judiciously, ultrasonography therapy, and surgical management. Now, referral to the allied health professionals, such as physiotherapists or podologists, is often necessary, and we must remember that. Traditional medicine or complementary and alternative therapies are also being explored.